Okay? Went back and looked at the x-rays again with the radiologist. Oh yeah, they're normal. Get a CT scan. And she has a perched facet at C4 and C5. Okay? She has some vertebral foramen fractures, and she has a dissected vertebral artery. So it's just, and even retrospectively, go back and look at the plain films, you can see it. Okay? That's our CT. So if you think something else is going on with the patient, okay, just go the extra mile. If you need an extra study, you need, by no means doesn't say shotgun a CT everybody from head to toe time you think something's going on, but use your gut. If you think something's wrong, okay, I tell you, many sleepless nights you go, oh God, I wish I can't skin that kid, or I'd have done this or done that. So use your gut. If you think something's going on, use your intuition. Okay? Sometimes you're going to be right. Sometimes you're going to be wrong. Okay? But use your gut. Don't ever document an exam if you didn't do it. Okay? One time we had an emergency medicine resident who was an ED doc in a trauma. He documented the ears were clear on a patient who was found down. He'd been down for a couple days in his yard. And of course, you get the ICU, he's got maggots crawling out of his ears. He did the documentation, the ears were clear. Don't ever document an exam if you don't do it. Okay? Be truthful. Okay?
My favorite was a medical student who wrote, eyesight was good in both eyes. The fundus exam was normal in both eyes. The left eye was a glass eye.
Yes. Or you full range of motion to all extremities, and they have a prosthesis, or they're having an amputation. Yeah, it happens. So big lawsuits, big lawsuits. Probably the number one missed lawsuit, kind of right now, right trend in emergency medicine, is an epidural abscess. Okay, do you know what an epidural abscess is? Is an abscess around the spine. Okay, that can occur. Big, million dollar. Compartment syndromes are also big. Now, obviously, anytime you miss some devastating injury, you have a bad outcome. But compartment syndrome lawsuits are common, and they're high dollar. Okay. So, compartment syndromes. Definition: types, pathophysiology, etiology, clinical evaluation, diagnosis, management, complication. So, the definition of compartment syndrome is an elevation of the interstitial pressure in a closed osteofascial compartment that results in a microvascular compromise. If left untreated, it can cause tissue damage. Compartments with relatively non-compliant fascial or osseous structures most commonly are involved, especially the anterior compartment of the leg and the volar compartment of the forearm. Types of compartment syndromes: acute and chronic. Okay? Sites: anywhere you have skeletal muscle surrounded by substantious fascia, you can get compartment syndrome in your fingers, in your forearms, okay, and your legs. Most commonly are the lower legs and the forearm. Obviously, different compartments. The foot has 9, the leg 4, hand 4, leg 3, forearm. One of the things that you guys need to document on a burn, this is a lifelong thing. Okay, if you ever have a burn, when you document a burn, you document either it is or is not circumferential. Okay, what does circumferential burn means? Okay, 360. Okay, so burns to a forearm, burns to a finger, burns to an arm or a leg that are circumferential have a very high probability of a severe burn to develop compartment syndrome. When you get that burn, that tissue shrinks and it loses elasticity and it swells and an increased risk of getting compartment syndrome. Okay, so anytime you have a burn, whether it's a firecracker or whether it's cold water, pan, whatever, you want to document that it's not circumferential, as long as it's not. You just determine whether it is or is not circumferential. Okay? So, compartment syndrome develops after prolonged elevation of intracompartmental pressure, which results from either external applied pressure or internal expanding pressure forces. Increased tissue pressure will decrease capillary blood flow, leading to local tissue necrosis caused by O2 deprivation. So, local blood flow equals the arterial pressure minus your venous pressure divided by resistance. Elevated intracompartmental pressure increases the local venous pressure, leading to an arterial venous perfusion gradient and compartment tamponade. If uncontrolled, can result in nerve injury and muscle ischemia. One of the things, I'm pretty OCD. I'm pretty anal. My background: I was an athletic trainer in college at OU. I worked as a tech in the ER at St. Anthony's. I got my master's, my MPH in health administration and policy, and then I started PA school. I was working in administration at Saints and working in the ER, and so I did a lot of splints. So I'm kind of a splint guy, and I take pride in my splints. And when you see some of the splints and how they look at other people, we put them on facilities, like, you want to do it yourself. One of the things that commonly happens is sometimes people can get compartment syndrome as a result of the splint being too tight, okay? So one of the things that, that we have to document, and we document when we're putting splints on, is pre-splint, as well as procedures, pre-splint neurovascular status. And then when you document your splint note, you have to document their neurovascular status after a splint, and did they tolerate it well, cap refill. And one of the things I always do, every time I put a splint on, I show the family or the patient, this is how you test for cap refill, this you have to test for pulses, and I verbally give them, instructions, and I document that too. Okay. So I'm really OCD about my splints. So cause of compartment syndrome, external restrictions, compartments, casts, tight dressing, splints, lying on the limbs. Okay, you get these people that found down, they're laying on their arm for a long time. Okay, they're down for 6 or 8 or 12 hours. People, mask pants. Mask pants aren't really used anymore for people who had a lot of hypotension. You put these pants that they were filled inflated with air to help increase and push the air up. But mask pants aren't used anymore. Burn eschar, closure of fascial defect, lithotic position, malfaction, and pneumatic boot. You have an internal increase in compartment volume. So fracture is the most common, obviously. Bleeding. In adults, you get closed and open tibial shaft fractures are the most common, as well as distal radial fractures in kids. Lots of times you get a radial head or neck fracture and supracondylar fracture. Bleeding, okay, you have a vascular injury, increased space. Coagulopathy, okay? People who have clotting disorders, they develop bleeding. And that's the thing with compartment syndrome, is you have an infinite space, and when you have all this pressure and swelling, okay, what happens is this pressure compromises arterial and venous flow. And when this swells and swells and swells, you impede venous return, impede arterial flow, you can damage nerves and vessels. And what happens to muscle tissue if it doesn't get blood flow? It dies, okay? It's necrosis, okay? Again, crush injuries are huge for compartment syndrome, okay? Every patient that you have fractures, you always want to talk about the compartment syndrome and what to do. Surgical related, you have surgeries and you have bleeding and hemorrhaging can cause compartment syndrome. Sometimes you send these patients off to CAT scan, they have an IV or an IV contrast CT to light up the vessels, and sometimes the IV blows and the IV fluid, okay? The IV blows as you have all this fluid into the subcutaneous skin, into the area, so that can cause a lot of swelling and pressure. Ruptured Baker cyst, muscle hypertrophy, and rhabdomyolysis. So the big thing with compartment syndrome, obviously not necessarily early, but pain out of proportion to exam, okay? And it's hard sometimes. It's hard now in society. You get these patients that walk in, they say their headache's a 10 out of 10, their pain's a 10 out of 10, they're eating Cheetos and they're laughing and they're playing Tetris on their phone and you walk in and examine them. Oh, my pain's a 10 out of 10, doc. Those are cutting up laughing and joking. But with compartment syndrome, pain out of proportion to exam, and you're going to know that, okay? Severe pain at rest, sometimes they'll get, you really have to sometimes ask patients the same questions 10 different ways to determine, to get the answer you want. Some people have a very hard time describing numbness and tingling, And so they say, hey, it's numb. What does numbness mean to you? What does tingling, So sometimes when you're asking patients, sometimes you can describe what they're going, but you get hyperparesthesias, so it can be very sensitive, it can be numbness, it can be tingling, severe pain at rest. Obviously, they have a mechanism to have a compartment syndrome, which is type of injury, like a fracture, or penetrating trauma, or crush injury. We get, in the emergency department, probably 4 or 5 patients a day sent for emergent care that have no business being in the emergency department. And lots of times, it's their lack of comfort dealing with an issue, okay? And when we talk about trauma and health in general, we're okay with over triage. We're okay with people being hypersensitive. But what you don't want to meet is under triage. So people, so at least if they're not comfortable, but they see people think of compartment syndrome all the time, and most of the time they don't. But tenseness, okay, feeling of the muscle, you got to know what tenseness feels like. I mean, people have fractures and they have sprains, they have swelling. Yeah, you have a little bit of pressure and it's a little tight, but you gotta know. It's like anything else, repetition. But with compartment syndrome, you're going to get a very tense, swollen, hard extremity. okay? Pain with passive, stretching of those muscles, hyperparesthesias, paralysis, pallor, absent arterial pulse. So pulses are the last thing to go, okay? Paralysis and pulses are the very last thing. If you got no pulses and pallor and somebody with compartment syndrome, you're late to the game, okay? It's a done deal. In medicine, they kind of go back and forth with the 6 Ps and the 5 Ps of compartment syndrome. Pain was pallor. Okay, paresthesia are kind of numbness, tingling, pulselessness, paralysis, and the poikilothermia is kind of the coolest type thing. When they did the 5 Ps, they leave that out. The big thing with clinical follow-up exams are important, like we talked about earlier, talking about neurovascular status. You got to keep evaluating these patients and determine if they have worsening symptoms. We had when I was at the review, we had a defensive back. He ran a 4.340. He came in after practice one day, and he put 2 ice packs anterior on his knee and 2 ice packs posterior on his knee. We iced for 15, 20 minutes. He went into his meetings for 4 hours, and he kept his ice packs on, and he developed drop foot, okay? So he froze his perineal nerve, and so, he could not dorsiflex his foot for the rest of his life. So imagine a college athlete going 4.340, now his drop foot for the rest of his life. Just something simple as a compressive ice pack on his leg. But one of the things you always want to look for is his range of motion, strength, plantar dorsiflexion, you the foot and the leg, numbness, tingling. You have to be very, very, very diligent in your exam. There was a lawsuit. I emailed the class last year, emailed it to you, on a compartment syndrome, and it was just really kind of came back to documentation, and he was a documentation team that got this PA sued for like $1 million. So, and the patient was at fault. He was given instruction to return if it worsened. So, a lot of times these attorneys, they'll come out and, they'll put some fault on the patient, some fault on the provider, but it all comes back to documentation, So, if you didn't write it down, it didn't happen, even though you said it, there's no documentation, So documentation is key. I got a call from an attorney a few years ago about a patient. He was a brain injured patient who he's the 45-year-old guy that lives at home with his mom kind of guy. Motorcycle accident, had a brain injury, had pelvic fractures. We had him restrained in the bed because he's at a fall risk because of his impulsiveness with his brain injury. Well, his mom kept untying restraints. And so it was documented by nursing staff and by everybody that, he was found on the ground, mom had loosened restraints, so we called an attorney, they were wanting to sue the hospital for him falling. And this has been 5 years for some patient, and they sent me my discharge. I was like, did you not read the chart? So these plaintiffs, these attorneys are like, just read it. It's all there. Of course, they dropped the case, but if you didn't document it, it didn't happen. Okay, very important. Even though you had a verbal conversation, you got to document it. So clinical evaluation of acute compartment syndrome may be delayed, okay, in patients with multiple injuries or altered level of consciousness. Okay, someone's unconscious, he can't tell you, hey, my leg's numb, I can't feel it. Hey, I'm in a tremendous amount of pain, okay? So relying on physical exam, okay, very important. Often children, okay? Sometimes when you're evaluating children, it's kind of the equivalency of examining a dog as far as being able to relay information to you about how they're hurting and where they're hurting, okay? The intelligent gait for a child is often very difficult to evaluate, trying to determine where they're hurting, okay? An extremity for a young kid, you worry about, do they have a Kevlex Perth disease, okay? Do they have a knee fracture, okay? Do they have a skiffy, okay? So it's very difficult. Sometimes you're talking to people who can't communicate effectively with them. That's when you have to hone in on family and their history and helping the child interaction exam, okay? So unconscious patients are difficult. It's like 5P/6Ps we evaluate for. So again, high index of suspicion, okay? For these people, what's one of the most common forearm fractures as a result of what in car accidents? Airbag. Exactly, your hands on the steering wheel, okay? Bam, okay? So a lot of times you get these both bone forearm fractures, okay? High force injuries, car accidents, motorcycle accidents, those high force things are increased risk suspicion for developing compartment syndrome, okay? Both bone, okay? Tib-fib fracture. If compartment syndrome is suspected, clinical examination is clinical inadequate, compartmental pressure should be measured. 30 millimeters is kind of the number. Okay, so there's your test question. So if you use a striker needle and somebody has, an elevated pressure compartment of 30 millimeters or greater, you are concerned about compartment syndrome. Okay? The pressure in all compartments will be measured, and the measurement should be taken closest to the area of the fracture site. So there's this little diagram that shows you that when you have an injury, when you have compartment syndrome and secondary fractures, the pressure is greatest at the site of the fracture. This is a striker needle. This is how you measure compartment pressures. And here's a step-by-step process you guys should read. I'm not going to read it all to you about how to put it together and measure pressure. This is something you need to know to learn how to do when you get out, when you guys do your rotation. The things that you should ask for, this is a skill you should learn, is I want to see your striker needle, okay? And I want to learn how to do intraocular pressure, okay, on the eyes. You guys could do it on each other, check it. But those are kind of skills. This is one of the skills you can't, you have to pick it up and you have to use it and learn to do it, okay? And what this chart shows you is that the closer it is to the side of the fracture, the highest your pressure. So sometimes you kind of got a confusing picture. This guy has a red, hot, swollen leg, Is his leg hot and swollen because of infection? Okay? Is it hot and swollen because he has a gangrenous infection? He has necrotizing fasciitis, he has a peripheral vascular injury, he has rhabdo, he has infection. And sometimes it's very, very hard. Okay, look at these patients that come in, that will develop, that have a spider bite. Some simple spider bite that turns into infection and they get necrotizing fasciitis. We had this girl she would shoot up, she was a drug addict, had no vascular sepsis, she's shooting up in her femoral. And, she got necrotizing fasciitis, took back the OR like 14, 15 times, debriding her leg, debriding the necrotic tissue, and they're doing skin grafts, and she had to have a central line, and one day we were getting killed, she was supposed to be discharged, and we were getting killed with traumas, we couldn't get up to get her central line to discharge, she left her central line and went shut up. She'd meet you in the elevator, wanted to show you her thigh. Look, it's doing great. She'd lift up her gown to show you her leg, and there's 10 people in the elevator, she has no undergarments on. You're like, oh, please show me. I believe you. But she would get MRSI cellulitis and come back and get it all the time. But sometimes it's hard. It's hard as, do they have a compartment syndrome? Is their leg hard and swollen because of cellulitis and infection? Sometimes it's really kind of hard to do. Sometimes get an ultrasound will sometimes kind of help you to look to see if there's tissue or a fluid pocket. So that will help with that. So management, obviously we talked about the striker hand needle. The other way that really is commonly used is getting an arc line kit from the ICU. You use an engine cap and put it in the compartments and measure it that way. But the striker needle is the standard that everybody has in most large facilities. So, when you have people that, if they're bleeding and they're on blood thinners, okay, you want to correct that, okay? If they're on Plavix or they're on Coumadin, there's things that you can do to help with that. If it's a constriction issue, okay, if it's a splint or a cast that's too tight, you can remove that. Positioning the limb above the heart, those are things that you can kind of do. But if there's something you can do to relieve restriction, it's an external thing. You always want to do that. How do we reverse anticoagulation in people on Coumadin? Vitamin K. What else? Fresh frozen plasma, FFP. Okay. There's a new drug out called Kcentra. It's kind of expensive. It's a new drug that's really kind of great. The 10A inhibitors, Xarelto and Pradaxa and all those medications. Pradaxa has a reversible agent. It's the first one out that has it, and the rest are coming. But that's the unfortunate thing is you get these people that are on Plavix. You have a 36-hour half-life, and you're just crossing your fingers, and you can give. There's a it's a 4-factor to protein-rich complex. I think PCC is what they call them. I think kind of helps a little bit. There's really nothing out there yet for it. So management of the limb, obviously you can treat their hypertension and shock and cooling the limb if there's a temperature issue. But management of ACS, essentially, if symptoms don't resolve after you try to manage these issues, then you have to do a fasciotomy. Okay? This is kind of a syndrome. So obviously, if you suspect compartment syndrome, and they unequivocally have compartment syndrome, they do fasciotomy. If you're really not sure, you check the compartment pressures. If it's greater than 30, fasciotomy. Less than 30, you continue monitoring. Okay. So most of the people in the trauma setting, we get these compartment syndrome, these people admitted, or people have just massive extremity injuries and fractures. definitive treatment we talked about is fasciotomy. And one of the things that happens, depending on how long they've had this ischemia, is determined on how long the effective treatment is. So if you get in there and you do this fasciotomy and there's lots of necrosis and dead, kind of foul tissue, you do some debridement. Lots of times you'll take them back to the OR in 48 to 72 hours. And depending on what you see at that point, you may have to do another debridement. And then you can do, obviously once you get rid of you get the healthy tissue and the necrotic is done, you can do a closure. Lots of times, like I talked about earlier, we'll do like an external fixator. These people kind of a temporary thing applied when you do the decompression and go back and do fixation of the fracture later. The double incision procedure is what's performed for fasciotomy. And here's your compartments. Your anterior compartment, your deep posterior, superficial posterior, and lateral compartments. So, these people do well, when you get on it quickly. If you don't get on it quickly, they can get infection and necrosis and have some other long lifetime issues. Sometimes they can be septic and get wrapped up in other issues depending on what's going on. And that's the hard thing, if it's, lots of times, if it's just a simple isolated orthopedic injury issue, these people do pretty good. But when they have a bunch of other issues going on, it's kind of comorbidities that kind of complicates your problem with these people. A Voltman contracture is something you can get when people get prolonged ischemia, essentially getting a bunch of scar tissue as a result of a complication of compartment syndrome. Obviously, we talked about neurovascular injury. They can get chronic nerve problems, drop foot. We talked about some of the infection. You can get amputation, you can get rhabdo, renal failure. Lots of times, people, sometimes these patients that have these disintegrated, multi-tib fib fractures, sometimes they go to the ER, they'll go into a prophylactic fasciotomy. Lots of times you get chronic compartment syndrome, and this typically occurs in people who are big runners, okay? And so sometimes this occurs, you've seen the bodybuilders, the guys that they can't walk right because their arms or legs, their muscles are so big. And so what happens a lot of times, these patients, they complain of a lot of leg pain. And the way to determine that is you'll have them check pressures. And this is a chronic thing, it's not an acute thing. You can have them check the pressures before the exercise, then have them to work out if there's a change in the pressures in 20 to 30s, kind of resting compartment pressure, and oftentimes it's in the legs. We're talking about in the calves for this. I don't really understand it, but I've seen 2 or 3 of those. Well, this talks about pre-exercise resting pressure at 15 millimeters or more, and a pressure of 30 1 minute after exercise, or a pressure of 20 millimeters of mercury or more after 5 minutes after the exercise. This is kind of a thing that sometimes you see these orthopedic surgeons, these patients come in, hey doc, I have this pain in my calves, it only occurs when I run. That's kind of the kind of thing. This is not an acute issue. Some other similar issues, sometimes you get entrapment of the nerves, or tendinitis can cause kind of similar type complaints. Or sometimes you have a stress fracture or intermittent claudication. You all know what intermittent claudication is? What is it? Pain that occurs with compression of your arteries, okay? Your lower legs oftentimes. So if you think somebody has chronic compartment syndrome, you can get x-rays to see if they have a stress fracture, or bone scan to see if they have peritonitis. Nerve conduction studies can help determine if they have a nerve problem. MRIs are things that you're really not going to see a lot of those studies unless you have something other than compartment syndrome. So kind of treatment of chronic compartment syndrome, you do anti-inflammatories, you massage, muscle relaxants. The hardest things for some of these big runners is like back off running and you'll get better, but that's the time to find the answer. People want to hear. And the treatment, obviously, if you don't get a result with simple things, they can obviously do fasciotomy. So compartment syndrome is something that you don't want to miss it. You got to have that. You always have to warn people. Okay, there's things that when you get out and practice, things that you need to do. And one of your documentation, your discharge instructions is always document I discuss compartment syndrome with the patient. I discuss risk of decreased pulses and power and cooler and darkness. And, you know, the thing I tell people a lot of times they have problems with their splint. If you start having throbbing pain, the first thing you do is elevate it. If you elevate it, doesn't help. The next thing you do, give a splint and loosen it. If it doesn't happen, come in. But you have to always, you're not going to find compartment syndrome if you don't have a concern and a high suspicion. So anybody with high force mechanism, both bone forearm fractures, you know, big extremity fractures, okay, or burns, you have to have that, you have to be thinking about it in the back of your mind. And you have to educate. That's our job, is to educate patients, okay? These patients come to us, they come to us for help. And so we need to educate them on what to look for, what the worsening symptoms are, instead of just relying on this crap of information we send home. You know, when you guys get out, these discharge instructions, they have these standard discharge instructions for every known diagnosis. And it's just a bunch of crud. You know, I'm OCD. I type out discharge instructions, you know, of my own for patients. And I know, that way I know they have a good understanding. If they didn't hear, I talk fast. I get it all the time. If I talk fast, so I write it down for them, okay? Where they can know and understand. So, compartment syndrome is a big moneymaker for attorneys. That's what me and Dr. Bennett were talking about earlier. It's like we do so many things in practice in medicine for fear of litigation. You know, for example, spinal cord injuries. Okay, people with spinal cord injuries, we have to solve this. It's a Solumetric protocol for spinal cord injuries. 70% of the data says it doesn't work, and most people, the data in academia says it doesn't work. But everybody continues to do it for the fear of these attorneys and fear for the other 30% that says it does work. So it's like we do these things. We do these things in medicine sometimes just because of fear of litigation. But read up. Read up and be knowledge is powerful. Know your studies. I read every day. I learn every day. I've been out since 2001, and I read little articles here on my phone. I read journals. I do a lot of CME courses. Medicine is evolving and changing every day. I mean, gosh, what you've seen in medicine throughout the years, not to make light of your age.
There weren't even any X-rays.
Well, you know, and that's the thing with technology. You know, you get all these general surgeons that come out and say, you know, when I was a general surgeon, I could diagnose appendicitis just by walking up and putting my hand on it. A lot of these general surgeon residents now, I mean, the skills, that's all they had was their hands. Now everybody, get a CT, get a CT, get a CT, get a CT.
Yeah, when I was a resident, you couldn't get a CT of the abdomen at the VA hospital without the signature of the medical record.
And lots of radiologists now, it's ultrasound. Sonographers make a lot of money, and they're kind of hard to come by. And so the radiologists really try to protect the sonographers. They don't like to be calling them in the middle of the night for these kind of cases that could maybe sometimes wait for an ultrasound in the morning. You know, so some hospitals say, you know, unless it's a pregnant female, you know, but a lot of these gallbladder ultrasounds, like, yeah, you can do outpatient the next day.
Yeah, so things are different and better, and you know, your access to technology will make you smarter and smarter quicker than we were. I want you all to thank Bradley for this remarkable talk, and I want to embarrass him for just a moment. As he was talking about the trauma center and the trauma system in Oklahoma, you got a taste of the fact that he's been involved in the development of this probably since 1998, 1999?
2001, yeah.
Yeah, 2001. And what you heard was probably one of the better demonstrations of a PA who has somehow gotten himself involved in a really, really important project that is statewide. He's on these boards, he's in decision-making situations in these important processes. So what I'd like to do is ask Bradley to talk about this, because I think this is maybe the strongest manifestation you've seen since you started PA school of what I call professionalism, where the professional not only learns what he or she's supposed to learn and is competent at their job, but they also see health of the community as really important, and are willing to invest themselves in the health of the community at large. So if you wouldn't mind just talking a little bit about how you got involved in the development of Trauma Center and the trauma system, and how you wound up being on all these boards and decision-making roles.
You know, I love being a PA. I love what I do. So, you know, when you have a job that you like and you love, it's not a job. You know what I mean? You know, we always joke about, we do interviews for PA applicants about, I do this, I want to help people. It's kind of a cliche answer, but, you know, it's really kind of true. You know, I'm that guy, you know, it took me 3 times to get in PA school, you know. When I was an undergrad, I knew a lot of important people and had some connections, and, you know, I had a 3.5 GPA in undergrad, and, you know, I worked 30 hours a week and had a lot of fun in college and did the things that college people do. But first time I didn't get in, it was kind of that slap in the face. It's like, crap, what do I do now? So I knew I wanted to be in healthcare. Got my master's in health administration and policy. I graduated grad school with a 3.98. And you know, I kind of got a well-rounded kind of picture about healthcare from not just from a clinician standpoint, but from an administration standpoint. So much of what we do in medicine is directed by administration, guidelines. Okay, you guys are going to learn about core measures, sepsis protocols, and community-acquired pneumonia. A bunch of stuff we do is ridiculous, but it's what you do. You have to learn medicine. But I feel so blessed to be where I'm at and what I'm doing. And I think one of the things that's been important for me is I feel it's important, as you guys should when you get out, is to give back to your profession, give back to your community, and help people out. I was so blessed to have great mentors along the way that you know, that took time out of their busy schedules to talk to me, to help me, you know, help me attain my goals. And so, you know, you guys are obviously goal-oriented individuals, and that's why you're here, and that's why you're succeeding, and that's why you're doing well. You know, when you get out, what you learn here today, it doesn't stop. I mean, medicine is evolving, and how we treat conditions changes daily, and you have to be up to date in what we do and how we do things. I'm very blessed that my wife is very forgiving and kind and understanding. I'm the guy that can't say no. You know, I get people asking me, hey, once you be on this committee or once you do this, and you know, quarterly meetings turn into 6 or 7 meetings a year, and you know, this committee and that board and that board. But my whole reason for doing what I do is, you know, I want to make things better for other people. You know, we're in a lot of these meetings. A lot of the meetings I'm in is kind of a lot of hocus pocus and listen to the health department talk about themselves and kind of whatever. I really get a lot of enjoyment out of doing trauma CQIs, continuous quality, and what that is we review cases. And all these cases have bad outcomes, and so what you're trying to do is find out what the problem is. Okay, is it a provider problem? Is it an education problem? Is it a system problem? You know, and you know, and when we do these cases, review these cases, it's not to be punitive. It's not to say, hey, you did a crappy job taking care of this patient. You know, it's not to do that. It's to educate and inform people to try to prevent it where it doesn't happen again. Okay, and that's probably the frustrating thing. Is sometimes when, as you can speak, when you're dealing with government and institutions and rules, sometimes they make it difficult for you to do your job and to do things. But that's, I mean, I try to better things. You know, what would, you know, if my family member was affected in some way, how can I make it better where they didn't go through the bad and terrible things you see people go through all the time? And you know, we get these. I'm in a lot of meetings all the time. People like, oh, y'all send us this letter, and how can we do this? And it's just, it's not about you. It's nothing to diminish the care to say that you did a bad job. We send out good job letters all the time. Okay, but I think that you guys, when you walk away from this facility, I mean, you guys are. I mean, when I was in school, we talk about technology. All the technology you guys have, and your computers, and these courses, and online training things that you guys have, you guys are so blessed to help feed you this information, because you guys are getting so much information in such a short period of time. Staying on top of the technology thing, if you guys, before you graduate, if you guys can afford out of your own money to do an ultrasound course, okay? Sonography, I know you guys get a little ultrasound exposure, but sonography is the new thing, okay? all these medical students are getting trainings in ultrasounds when they're out. So, using ultrasound, intubations. The big trend in intubations are video laryngoscopy, using video assisted. Okay, same with ultrasound. Central lines in the trauma bay, we put them in blindly all the time. Okay, it's a technique, it's a skill. Now, if you have a complication of dropping someone's lung, getting into a thorax, doing a central line without doing ultrasound guided, they're not going to pay you for it. So, so ultrasound is being used in so many different manners it needs to use, and so kind of keeping up with the evolution, I think, of learning direct and indirect video laryngoscopy, using ultrasounds. Those are things that you guys really can help give you an edge, when you're out there. I know you guys are getting some ultrasound. We're coming to give you some courses, but ultrasound is kind of like EKG. You get a little, you look at one or two, it's fine. It's just repetitions. You got to get used to looking at things, and give back to your community. Make a difference. That's to me, it's what it's all about. Try to make things better. That's kind of how I. And it gets me in trouble with my wife sometimes. This last week, I taught I did on my own time. I taught a tactical combat casualty course at the Clinical Skills Lab at OU. And then we did an active shooter drill at Western Heights. And then I had to be part of the tactical canine course. I learned how to take care of these dogs when they get shot. The SWAT teams have these, the police have these dogs, and their handlers. It's kind of crazy. It's just this whole course for how to, it's essentially like ATLS for animals. They had a bunch of suits some of these police officers put on with the dogs attacking. It was pretty scary. But, I guess I learned if you have a handler, if a dog handler goes down, oftentimes they have to put the animal down because the animal will not let anybody care for the handler of the dog. Which to me was kind of crazy. They spend $40,000 in training on a dog. If you have a handler that goes down, they can tase it sometimes, but if they can't get control, they have to put the dog down. Which to me is crazy. Kind of leery of these dogs, but so I'm pretty active. I'm not going to say no. So I'm pretty active in doing things, but again, I think it's all means to an end.
Thank you.
Thank you.
We've got about 15 minutes before.